Hello again, everyone. Hello, everyone. I'm very happy to see you again during this second day of the conference. And I'm very pleased to welcome you to the second plenary session of the conference organized by l'École des Hautes Études en Santé Publique. This session explores how innovation can contribute to improve health for all, which is the topic of our conference. Without further ado, I would like to introduce you to the facilitator of this second session. This is Dr. Olivier Grimaud. Olivier, it's yours.
Thank you, Catherine, and welcome to everybody in this lovely, sunny School of Public Health. If you look for the sun, it's not outside, it's inside this amphitheater now, all right? There's always some sun in Brittany, you just have to look for it. So as Catherine said, we are focusing during this session on innovation. I think, all of you are involved into detecting or implementing innovation, so it's not surprising since this is at the heart of your job that we are focusing on this topic. So we will have a session. I think I need the next slide. Thank you, Isabella. If it works. This session is organized in two parts when we will listen to three guests who are here to witness about their experience on technological, organizational, or managerial innovations. And then we will benefit from the view of our other guest, Kasia, who is sitting at the right-hand side. I will introduce her later on. Who will reflect on this presentation and take a wider view of innovation from our standpoint. So this, can we have another? Yeah, I can. Thank you. We also like in the second part to benefit from your view on innovation. And if you could take your telephone or your whatever, or key in, so either scan the QR code here, and you have three questions that we will try and synthesize at the end, in the second part of this session, to feed in the feedback second part of this plenary. So thank you for doing that. You can also enter, go to wooklab.com, and the event code is EHMA25 capital letter. So easy. Right. So without further ado, I will introduce the first speaker. We concern technological innovation, and it's my pleasure to welcome, I would say, back Etienne Mainviel, because he's a former member of this lovely school. Etienne Mainviel is currently director of the Centre de Recherche en Gestion. I didn't dare translate that, Etienne. You might do that. At the prestigious École Polytechnique de Paris. So, Etienne, the floor is yours. Thanks for coming.
Thank you very much. I'm very happy to be back, as you say, in this lovely school. And as I have 15 minutes and I have to respect the time, I start just by showing my experience about digital transformation. And just to give you some keywords for starting about digital technologies in the area of healthcare, of course, you have a lot of definition. And I would like just to give some repairs. You can see on this slide that we currently talk a lot about big data on AI and the role that it can have on the healthcare delivery models. But beside, you have, since I would say the last decade, different innovation related to digital platforms. You have electronic and connected tools, and you have this specific area of telemedicine that you certainly know, and that encompass different kind of telemedicine, teleassistance, teleexpertise, teleconsultation, and telehealth. From a management standpoint, when we talk about digital innovation, one of the main questions we have in mind is to know if we face a disruptive innovation. So what is a disruptive innovation? And I would say that this smartphone is a disruptive innovation. I'm not going to give you a lot of definition, but I like the one given by this very serious journal that you probably know, The Economist. He made a study a few years ago, and they said that a smartphone is a disruptive innovation based on two facts. The first one is that 95 to eventually 98% of person shows look at their smartphone 5 minutes after their wake up. I don't know if it's your case, but that's my case. It is one of my first action when I start to wake up. And I don't know how they do in methodological terms, but they affirm that 25% watch their smartphone during their sexual activities. So this is a very good definition from my point of view, because it proves that it is completely anchored in the everyday life. So what I want to show in this slide is the fact that you can see the time required to adopt a digital innovation across the different centuries. And you can see that, for instance, for electricity, it has required 46 years until 1/4 of the American population use electricity. And you can see for telephone it was 35 years. And if we go on this part of the slide, you can see that for smartphone it's only 2 years. And probably with ChatGPT at this current time, it's less than 2 years, just to highlight the fact that the innovation, when it is a disruptive innovation, goes very fast in terms of adoption, and that we have to face many challenges in this case. In fact, this situation is not the most frequent one. The most frequent one is innovation that we call incremental, which means that they have a pace of adoption quite different. They have 3 steps. The first one is illusion. The second one is disillusion. And the third one is what we call second maturity time. I wouldn't like to be provocative, but if we talk about the story of the electronic health record in France, we can see that we have known the illusion time in 2004, and then after a big period of disillusion during, I would say, 10 years or more, and now probably we are in this situation of relatively important adoption based on the maturity of the system. So now I want to more focus on a specific case, digital remote monitoring case that we developed in Gustave Roussy, which is a leading cancer center in France, from 2015 until 2022. So this system is based on apps that you can see on the center of the draw, and patient can contact through an app or a computer nurse navigators during all the daytime. Then the nurse navigators can react by making 3 kinds of decisions. The first one is to give advice to the patient directly. The second one is to orient the patient to primary care providers. And the third one is to refer to the oncologist, of course, in case of emergency. So that was on this design that we tested. We have tested through a randomized controlled trial the impact of this digital technology. And we have shown, we were one of the first, we published in Nature Medicine, positive results on quality of care, patient experience, and cost control. We have shown that thanks to this digital remotoring, we were able to have a better dose intensity, which means in concrete terms that patients receive more dose of chemotherapy. Related to the definition of the protocol, we avoid the degradation in terms of toxicity, so we remain at a level of minor toxicity and not severe toxicity. And also about cost control, we were able to show that we reduce the day of hospitalization. And last, patient experience was also in the Capri arm. We have also shown, I tried to show through this case how we can assess digital technology. We have also shown that there is a positive return on investment for the social security system. You know that in France we are always in crisis, but it is quite true at this current time in financial terms. And so we try to find new healthcare delivery systems that can allow to have to reduce burden, the financial burden. And in this case, we can show the big question when you show in this kind of digital monitoring system a reduction of hospitalization is to know if you don't transfer the consumption to the ambulatory care sector. And we had the data for trying to understand, to have the answer, and we have shown that was not the case, and that the economy per patient is around 400 euros. So this is an evidence, that's not the only one, that through digital remonitoring, you are able to have economy in the healthcare system. Last point I would like to share with you is the primary role of nurse navigators. I don't know if you remember in my draw, patient contacts through the apps nurse navigators. They don't contact oncologists. And that's a key point to have what we call these intermediary actors, because they are able to select the information and to treat a lot of information without the help and the assistance of the oncologist. And we have shown that, for instance, they are able to treat around 3/4 of the question asked by the patient without, again, referring to the oncologist. So, then after, when you develop this kind of experience, a key question is to understand how you scale up what we call the proof of concept. What I just shown is a proof of concept. Then after, the next step is to understand how you can industrialize this kind of proof of concept that give evidence of a positive impact. So I would like just to outline the fact that it is not an evident situation, because you have to deal with startup or companies, industrial companies. Some people in innovation management call that it is a valley of the death, because in fact you have two different kind of representation about the development that you have to combine. We had the chance to discuss with Resilience, and Resilience has been able to use the proof of concept to be reimbursed by the Health Authority for Health, and then after to develop a commercial solution based on the Capri program. The other point about scaling up is the fact that when you begin to implement digital remote monitoring, and more generally digital technology, you face different challenges related to the general notion of adoption. So you have questions about healthcare professionals. You can have a gap between the expected and the real use. For instance, we always talk about coordination, but you can have what I could say sometimes some tensions between different groups of healthcare professionals, which means that in fact you don't confirm this expected use. You can have a current problem, the fact to introduce such digital technologies in overheated healthcare system. I mean by that it is quite difficult to find a nurse, for instance, each morning to assume the routine care. When you try to introduce innovation, you have, of course, to face this situation, which is not something in favor of the innovation. We call that, in our jargon, organisational ambidexterity. And then after, you have the adoption by patient, and it is quite evident that in Capri case, and I think it's not isolated, you have to combine the digital technology like a smartphone with a common phone, and that the role of the nurse navigator is to understand when they have to use the apps or the technological innovation on one hand, and when they have to continue to dialogue with the patient with classic communication channels like the phone. We learn also that digital platform is a new way to collect data on each patient needs. So you probably heard about patient-reported outcomes. It's a kind of new industry, and you can have patient-reported outcomes. It has been very spectacular at Chicago at the Oncology Congress in 2017, because Ethan Bass showed that a cohort of patients with cancer, only with the use of patient-reported outcome, improve their expectancy of life significantly compared to the control arm. And that was very impressed because the difference he has shown was quite similar to the difference that you could observe with the new drugs, immunotherapies or chemotherapies. The only point about that we also observe when we develop different studies is that, again, there is a question of implementation. PROs is not something so easy to adopt for patients. For instance, in oncology, patients have often a very high level of fatigue. And so when you ask them on a weekly manner, for instance, to fulfill a questionnaire, they don't accept with so much evidence. Last, just I think I am on time.
Yes, you are.
Good. So the last point is about how digital remote monitoring and more generally digital technologies can reshape the care organization and create new healthcare delivery model. I would say that there are two trends that we can notice in our modest experience. The first one, it improves the hospital outsourcing. In oncology, I don't know if you know, but the patient passes the majority of his time or her time outside the hospital. Almost 95 to up to 98% of his time is outside the hospital. So it is, at this current time, a key message may be to say that hospital has to stay, of course, a reference for the patient, but they have to organize the follow-up on the remote monitoring of patients with a big data center and to understand how to organize into the patient pathway the different steps of the patients. The second trend is about the role of digital remote monitoring for creating, I would say, new healthcare delivery model. From our point of view, we have the feeling that thanks to digital technology, we can capture a lot of data. And this data, when you have very good database and very good data treatment, can lead to what we call more personalized answers and more personalized care. For instance, if I have time, just to show you what we do at this current time, we work on the motivation of patients for the compliance of the treatment in oncology. We use psychological grid, and based on that, we capture different data about the level of motivation of a patient, and we can understand how we organize a personalized remote monitoring depending on their level of motivation that can move across the time. It's something relatively volatile. So, just to end, I would say that digital technology may have, I remain cautious because in certain cases, probably that's not that we don't observe a positive impact. It depends certainly on the design that you build around the digital technology, but it may have a positive impact on quality of care, patient experience and cost control, the three pillars. Digital technology, of course, can't be standalone. It must be combined with healthcare professional and patient expertise. It's something relatively consensual. AI and digital platform, of course, must be discussed with the role of nurse navigators and other healthcare professionals. Also with a digital attitude of patients for reporting, for instance, data like key PROs. But more generally, with AI, we see that one of the key aspects of the development is a collaboration between the technology and the human expertise. And last, digital technology leads to new organizational care models, hospital outsourcing, and, as I previously said, personalized care management. Thank you very much.
Thank you very much, Etienne. You could have spoke for a much longer time, so thank you for keeping to your time. As you know, healthcare systems are a very complex organization with many components, and it's proving increasingly difficult to provide seamless and accessible care. So it's my pleasure, and we are lucky to welcome Dr. François Braun, former Minister for Health and Healthcare and Prevention. And he will give us an account of his experience in devising and implementing an organizational innovation. So, Monsieur le Ministre, cher François, the floor is yours.
Dear facilitator, cher Olivier Grimaud, ladies and gentlemen, dear colleagues, I'm very, very happy and very proud to come back here in this amazing school and amazing place. And thank you to the organization for giving me the opportunity to explain a new organization, an innovation, a recent innovation in the field of emergency medicine, le SAS. That means something like Emergency Care Access Service. The context in emergency care is now well known. As you know, there is an increase in health needs. This increase is about the aging of the population and, of course, with the growing of chronic disease and the amazing growing of treatments, especially in cancer, for example. Second point is a reduction in the supply of care, not only because the less number of caregivers, but more because of the change in our relationship with the work. There is less time now for the patient. For example, in France, we have the highest number of physicians that we never had, but the time for the patient is reduced. Third point, and more complexity in the clinical pathway. That means that patients are often lost inside of health system. In emergency care, the consequences are well known. First, of course, the overcrowding in our emergency department or emergency units, because the growing of demands, as you can see here, not, of course, during the pandemic, but it's always higher and higher. That means that patients stay longer, too longer, of course, in our units. In PubMed, I just took a look on PubMed, there is more than 1,400 publications, the majority in the last 10 years, about this overcrowding in our emergency unit. And with a second consequence, not only a patient dissatisfaction, of course, but an unacceptable excess of mortality, especially for elderly patients. You can see in this French study the excess of mortality of 46% for all the patients who spend one night inside the emergency unit, and this percent is 2,020% higher for elderly people. Of course, it is not acceptable. We have to change, facing this situation, we have to change the paradigm, because this situation affects not only France, but all countries. We have to build a new organization, no longer based on the provision of care, the possibility of care, but on responding the real health needs of the population. That's what we have to do in the next year, I am sure of that. And for that, of course, I have to salute the success of Paris Saint-Germain, because we need, for this system, for our system, we need a real gatekeeper, and a good one, of course. To keep the gate in emergency care in France, we have a reputable organization all around the country, is the SAMU. You know perhaps the SAMU, it's an emergency medical call and dispatch center. The concept was born in 1958 by Professor Maurice Carra. It was during the poliomyelitis pandemic, and to take care of patients during the transfer between hospitals, Professor Cara said that only a doctor knowing well the reanimation, the intensive care in chest disease, has to decide what to do. And it was the best to have a doctor on the phone to decide what we have to do with our patient. Professor Maurice Cara, it was in Toulouse in 1960, not Cara, sorry, Professor Laringue in 1964 extended this concept not only for the transfer of patients between hospitals, but to, in the field, emergency care. A few years after, Simone Veil, it's a good place for celebrate Simone Veil, Minister of Health, gave a national call number for the SAMU, it was 15, and in 1986, the same Louis Laringue, he was a senator at this time, will pass a law about the emergency organization in France. In 2019, Professor Agnès Buzyn, Minister of Health, developed with the partnership of the professional organization SAMU Urgence de France, the evolution of this SAMU to the SAS. The concept was developed by a group around Professor and Dr. Patrick Goldstein. The concept was very simple. First, to have a general practitioner side by side or phone with the emergency doctor to respond to calls recording more for general medicine more than emergency medicine. To bring together professionals at the same place with the same practice and the possibility to help each other, and then to make a single entrance door the easiest as possible with a single point of convergence of all the phone numbers for emergency and unpredictable care, and one phone number, the 15. The doctrine, it was a simple tool. It is not to the patient to define their emergency. It's a crucial point. Remember that the definition of a medical emergency by the American College of Emergency Physicians is medical condition of recent onset and severity that would lead a prudent lay person possessing an average knowledge of medicine and health to believe that urgent and or unscheduled medical care is required. That's the definition for the emergency. The target of this system is to bring to each request the most pertinent pathway, which is not only to go to the emergency unit, of course, and to have a national organization to bring quality or equality all around the country. For this, we built a new organization with a two-level filtering organization on phone. The call, first, it answered by a professional, and in less than 30 seconds, 1 minute more, he has to determine in which sector he will be treated. The general practitioner sector, the emergency doctor pathway or sector, or perhaps, that we hoped, something more with a psychiatric way or a pediatric way. I will explain you later. What was the result with this two filtering organization? Immediately, this two filtering organization improved response, time and quality. It was better, of course. As you can see in this curve, it was the quality of response, the rapidity of response, the quality of a 20-second response. It was decreasing. Here, you have the two-level filtering organization, and immediately it was better in the quality of response, the time to response to the request of the patient. Okay, this one. Okay. The COVID-19 pandemic, it was really a test for the two-level filtering organization. And with this two-level filtering organization, it was very easy to build immediately another way, this one, especially to the COVID-19, side by side with the general practitioner way and the emergency medical way. And this solution, it will not make a difference for the quality of response in the emergency way. It was the SAS, and we have now to develop the SAS all around the country. Now we can say that 98% of the French population has today access to this new service, this evolution of the emergency service. It was first the experimental phase, and now we had first an initial distribution between the emergency service and the general practitioner service. Now we have more and more possibility. It was enriched with new channels, sometimes channel at the regional level, not only at the level of the French département, but a regional one, and sometimes inside the first organization of the SAMU. And this new pathway, this new solution with new possibilities, it's often dentistry, it's psychiatric, it could be toxicology, and pediatric care, and perinatality care. With this solution, we can offer more and more possibilities for the patient, with always a physician behind the phone number, and a different physician, of course, in each pathway. Today, according to the governmental plan against medical desert, the SAS, the medical dispatch, is a good answer too for the emergency overcrowding discussion today. By checking the emergency unit entrance by a medical dispatch or a medical regulation, for the first time in years, the frequentation of emergency units decreased by 15%. It's really a new evolution to come inside the emergency unit. And by the way, last week, the Conference on University Hospital requested the development of all the possibilities of the SAS and systematically a medical regulation before the access to an emergency unit, just like I think in Denmark, it's the way to go inside the emergency unit. You know, I like Churchill. Of course, it is not the end of the SAS. This is, I'm sure, the end of the beginning, but we have a lot of things to develop now with the SAS. First, this is a recent publication that explores the possibility of a community of the SAS working together on the same large area, and with this community of the SAS, there is a better possibility to absorb the peak of calls. It's now just, you can see here the peak of calls during different phases. Of course, when you have a information campaign for the population to call the 15. It was the triple epidemic last winter. And of course, with the growing of call, we have a decrease of the quality of service. But working together on the same area, it could be better, and we could continue to have the better quality of response. That's the first evolution. The second one, of course, is the utilization of artificial intelligence. You have here some result. It's confidential. It's not yet published, but it's very, very interesting. You have one of the artificial intelligence for the SAS and the regulation. It's about the call for a general practitioner, and you have that this tool, it's always a tool, the artificial intelligence, can catch back 90% of misdiagnosis of stroke. It's very, very interesting. It's the same, there is the same result for the cardiac arrest. So tomorrow, the AE will be usually used in our medical call center, of course. I'm on time? Just a little one? Okay, it's the last one. It's my conclusion. My conclusion, it's for the emergency organization. It's always for the evolution of our healthcare system. I am sure, it's Charles Darwin, a great man, sorry. I am sure that in our evolution, in our time, it is not the stronger, it is not more the most intelligent that will survive, but the most responsive to change. That's what we did with the evolution of the SAMU to the SAS, and perhaps the evolution in the next year. Thank you.
Thank you very much, François. So we're probably moving to our strongest and most intelligent speaker. But we said that, earlier that managers, they have to detect and implement innovations. So Virginie, one hopes that they can also apply this own medicine to themselves, and they hopefully, and develops innovations in their own functions. So I'm very pleased to welcome you, Virginie Valentin. You're Deputy Director of the Lyon Teaching Hospital, and you accepted to share your experience about innovation in the field of management.
So good morning, everyone. I'm truly delighted to be with you today to share a conviction that drives much of what we do in the Hospice Civil de Lyon, which is the second largest university hospital in France. The question we always have is, what if managerial innovation became the beating heart of our university hospital? That's how I decided to deal with the subject this morning, the subject about managerial innovation in hospital. I'm not a scientist, I'm not a researcher, I'm a professional, so I will share with you my experience, my observations, so it's only the real life I will talk about for 15 minutes. We often associate innovation with technology, research, or clinical breakthroughs, but an hospital, to my point of view, cannot truly evolve without also rethinking how it is managed. In a time of overlapping crises, health, social, ecological, geopolitical, and maybe democratic, the way we need and the way we lead teams, the way we support collectives, and open decision-making to collective intelligence has become a strategic imperative in the healthcare system. So today, I'd like to take you on a brief journey, structured on 7 key points. A journey to reflect together on how we can restore meaning, rebuild trust, support managers, and make management not just an administrative function, but a powerful driver on transformation in the healthcare system. First of all, we have to admit that, and you have to believe me that I don't like to talk about crisis in the hospital. The hospitals are in crisis, and this crisis is systemic. For several years now, and especially since the COVID crisis, a lot of studies, investigation, field accounts, or newspapers have confirmed that many caregivers, what many caregivers feel every day, that the hospital has troubles, the hospital is in crisis. And this crisis is not only financial, economic, it's deeper, structural, cultural, it's evident through different warning signs: staff shortage, burnout, disengagement of professionals and managers, fragmented care pathways, a growing gap between the hospital missions and its operational reality. Or, maybe to be fair, the way operational reality is actually felt on the ground. And yet, I really deeply believe that the hospital remains a vital space, a space of science, a space of care, a space of humanity, and a space for collective dedication. Actually, a place where public interest takes shape in real time. So the real question is, how do we reconnect the hospital to its purpose even its soul, so that it continues to inspire commitment, inspires pride, and hope for professionals and students, because in other words, the students are those who will shape the healthcare system of tomorrow, so we have to take and deal with that. What is obvious is that we are right now in an uncertain world, and this uncertain world demands a new model. We have entered a world marked by unpredictability, with healthcare crisis, ecological transition, digital upheaval, and a shifting social contract, and the rise of mistrust in institutions, and we have to admit it also, and in science and knowledge. So in this world, the hospitals can no longer rely solely on norms or control. They must become resilient and robust systems that can absorbing shocks, maintaining care quality, staying aligned with its value despite instability, and developing social interaction and social cohesion. But resilience or robustness don't come from rigidity. They come from agility, from collective intelligence, from meaning shared across all levels. This is where management becomes not just an operational tool, but a powerful investment for transformation, a way to restore a sense of usefulness for professionals. That demands restoring meaning to hospital work. Meaning is, for me, the invisible fuel of public services, the way public services are quality services. But today, it's being eroded by overload, by a lot of procedures, and by moral distress. And we can see three major disconnections: a dissonance between personal values of people and systemic constraints, a loss of visibility because people no longer see the purpose of what they do every day, and the disappearance of spaces very useful to discuss good care, ethical dilemmas, or of what constitutes quality work. To restore meaning, we must create time and space for reflection and dialogue. We must involve teams in shaping how care must be delivered. And we have to reconnect every task, however technical it is, to its human and social purpose. That's not a luxury. It's the condition for commitment, for quality of care, for efficiency in our hospital. And I believe that it's the first and surely the foremost responsibility of managers and of directors, and we have to deeply believe in it. So how can we strengthen work collectives in the hospital? Hospital is not a collection of individuals. It's an ecosystem of interdependent teams. And these collectives are under threat right now because our organizations are complex, there is staff turnover and pressure that pits professionals against each other. However, in crises, we have seen it during the COVID crisis, these collectives make the difference. They offer mutual support, preserve memory, distribute stress, and allow for improvisation when the script no longer fits. So investing in collectives means supporting interprofessional dynamics, valuing informal cooperation, and creating the condition for trust and sense of belonging. And to succeed, we have to transform right now managerial mindsets. Management in hospital has long been vertical, focused on transmitting orders and enforcing compliance. But that model is reaching its limit and we have to change it. Today's managers must shift roles, from controllers to enablers, facilitating team coordination, encouraging professional initiative, and creating the conditions for quality work. This calls for autonomy at local levels, for trainings in relational skills like listening, like mediation, like recognition, and a cultural shift from execution to support, and that's the first responsibility of manager. because the good manager is no longer the one who knows and who decides everything. That's quite easy to do, but the one who holds spaces for others to act with meaning and confidence. But transforming manager mindset is not enough. We have to promote a new model based on opening management to the ecosystem, because hospitals are not islands. They are deeply interdependent with their ecosystems. The quality of care depends not only on internal resources, but also on relationships with patients and their families, with outpatient professionals, with researchers and universities, with local authorities and social services, and with innovation partners. Managerial innovation means building open governments that can involve users in care design, co-develop territorial health projects, and create innovation platforms that welcome ideas from inside, of course, but also from outside the institution. We need dialogical governance, accepting uncertainty, and adjusting course through dialogue and experimentation. And that's exactly the moment when innovations becomes transformation. What I try to explain you for a few minutes is that it's not only a theory by my words, that's what we are trying to build step by step at the Hospice Civil de Lyon. We've anchored on managerial transformation in concrete systemic actions, which I'd like to share you with 3 short illustrations. That's the pictures that you can see on screen. The first illustration is our co-design strategic planning. In 2024, last year, we launched our strategic plan called Hospice Civil de Lyon 2035. We didn't want to write it behind closed doors, and so we brought together professionals, patients and family caregivers, medical students, and external partners. 150 of them were gathered to build the vision of the future of our hospital during 3 major conferences that we called Agora. They discussed, those 150 people, the transformation of our healthcare system in Lyon, the role our hospital has to prepare the consequence, and the vision of how we want to develop our missions of advanced care, of medical research, and of health training for the next 10 years. And we decided that every voice would count. The result, a shared vision of tomorrow's hospital, rooted in experience and designed for relevance. And at the end, this vision deeply links medical technology to relationship, medical progress to ethics, and human values of giving care. That's not just inclusive, it's smart, because transformation only works when it's co-owned. And today, we have a robust strategic plan with 6 ambitions for 2035 and 10 programs of transformation that connect all our stakeholders and that we will realize with all our stakeholders. The second illustration I want to talk about this morning is our calls for interest to stimulate bottom-up innovations. We launch regular internal calls for projects focused on technological innovations, on social and ecological transformation, and innovation in organization and managements to strengthen work collectives and to develop strong partnerships between caregivers and patients. Teams across the institution respond with creativity, and that's quite nice to observe. We, for example, develop dissemination of eco-design care projects for a more sustainable health. We promote peer support and better acceptance of care and illness by patient-led programs, and we create an entrepreneurship training course to develop medical and biotechnological innovations co-produced between our professionals and our institution. This is a powerful shift, recognizing that frontline staff are not just executors. They are innovators, they are observers, Actually, they are designers of better healthcare system, and our role as hospital managers is to enable and to amplify their energy. And the third illustration is the way we built a culture of recognition and lived experience, because we've worked to make room for stories and not only for metrics. We invite professionals and patients to co-build and co-evaluate projects, share lived experiences, and speak about what matters to them. For instance, we did that for our policy about disability inclusion, co-built with professionals and patients living with disability. Their experience helped us to create and to define our policy. We did the same for equity and anti-discrimination, developed with hospital workers from all backgrounds. Many of them has been faced to troubles about equity or discrimination. I have to be honest, the experience in the Hospice Civil de Lyon is not perfect, but it's real. And it changes how people can see their workplace, not as a constraint, but also as a place for shared projects and a place where potentials can always express themselves. This is exactly the spirit behind our employer brand. I'll try to show you this one on the right side, that we call Here I Can, Ici je peux. This is exactly what we want to do every day with all our professionals, but more and more with our patients and with our partners. It's a declaration of trust about all the people we work with, a declaration of possibility and of belonging. And in the end, I hope that I convince you that managerial innovation is not about adding more tools or rules inside our hospital. It's about reconnecting to meaning, to teams, to the outside world, and to those who care for others. Because the hospital of today and the hospital of tomorrow must be more than a place of healing. It must be a place where people create together, evolve together, and continue to act and to promote the power of care together, no matter the conditions, right now or in the future. And we know that the future has never been so unpredictable. Just one word. By reconnecting with that truly matters, the meaning of care, the meaning of work, the meaning of human connections, and in other words, the right way to re-enchant the daily life in our hospital so that we are able to give the best of ourselves, quality care for our patients, and caring and learning environment for our professionals and for our students. Thank you very much.
Thank you very much, Virginie, for these strong messages. So we come to the second, much shorter part of this session. And you can, if you haven't answered the little poll, the 3 questions on the QR code here, there's still time to do that. But in the meantime, we would like to, we thought it would be nice to have a wider view of the questions of innovations and all the 3 presentations that we have done. And we offered this very difficult task to our dear friend Kasia Szablonska. I hope she remains a friend after that. But with whom we have a very long and fruitful collaboration and within school. So Kasia is a professor for public health and leadership and workforce development at Maastricht University. Kasia, the floor is yours for your take on innovations, please.
Thank you very much, distinguished panelists, dear Mr. Chairman, ladies and gentlemen. We heard 3 stories about innovation and 3 different stories, including digital innovation, managerial innovation, emergency innovation. But all these 3 stories have 3 elements in common. First is change, leadership, and transformation. Concerning change, when we introduce change, there are always 2 factors that we need to consider. One is threat, and one is an opportunity. when we think about exponential innovation, which was mentioned in the first presentation at the beginning, when some kind of digital transformation comes, and we don't even think about it, but adopt it very quickly. But when people are involved, the change can come with threat. People are afraid. And leaders in healthcare need to know how to minimize this threat and how to maximize the opportunity. And what happens then? Around the opportunity, we create the feeling of urgency. Healthcare is in the crisis. We need to change our pathways. Patients are dying. So the urgency, so sitting on the verge and reaching a tipping point, and then we have to change. And as we listened to our colleagues, through their stories, we identified steps that have been taken during the change. They created at the beginning a kind of guiding coalitions. So those who would be with them, stakeholders, colleagues, and created this feeling of urgency together. Then they developed the mission, vision, and designed the way to introduce innovation. And then there was a next step to empower action. I heard something about nurse observers. Yeah. Navigators, nurse navigators. So we need those who would empower the action, who would be champions in the change process, and we rely on them. And then there will be some small wins. And as leaders, we need to enhance those small wins so that people buy in and want to follow. But that's still not the end, because we need to see the result. And then we need to evaluate and perhaps change, but we can't give up. We have to make it stick. So it has to be embedded in the organizational culture of the institution, or in the format of a law or regulation. But now the second is the question, so how healthcare leaders can make sure that they introduce and implement innovation and that it sticks. And here I would like to refer you to different levels of leadership. So first, on personal level, everybody in the organization, every leader has to think, what do we stand for? What are our values? And I here refer to the third presentation. What do we want to do? How do we want to benefit our organizations, patients? And learn. On the second level, leading others, we need to develop the culture of integration, of listening to colleagues, of diversity, and of clear communication of our vision. And the third level, leading other leaders, and I think it is very common, which is a difficult level, leading other leaders, but here we can do a lot. We can help design, develop pathways, create ethical guidelines, and also help to scale up at this level the innovation, and also develop a culture of mentoring and training so that people are at peace with innovation. And the final level is leading organizations and systems. And here, a role of the leader is to connect with different stakeholders, different sectors, organizations, and create the environment in which people can be safe and work safely. And there is also one thing that can be added, that the culture of innovation is introduced in the performance metrics in the organizations, so that we look at managers and leaders who show in their assessment plan that they are really steadfast to innovation, that they learn, that they know what to do. And now the third one is transformation. So what to do for the innovation to be transformative? And here we need transformative leaders, those who are adaptive, those who are able to challenge the status quo, those who are inclusive, those who are ethical and fair at all times, and those who have a little bit of entrepreneurial skills, and those who can combine the evidence with empathy for another human being, and who can empower action. Thank you.
And now we are going to review the results of the survey you are responded to. The results are both unsurprising and reassuring. The first question was, which one of these three categories of innovation is more likely to improve health for all? And the answer is organizational innovation is the best one. The second on the podium is managerial, and the third, I'm sorry, Etienne, is a technological one. Okay, and it's a little bit unsurprising. Now, which is reassuring is the second answer. Do you think that your organization is prepared to embrace innovation? Most of you said rather yes. So 63% of the 91 respondents. It's a good rank and a good score, and thank you so much. And after we ask you, can you describe in one word as innovation, which is your experience made a difference? And what you said is artificial intelligence, data, and integrated care. But the most of them is artificial intelligence, data, telehealth, integrated care. We thank you very much for these answers. And to conclude this survey, I could say that Darwin may be satisfied. We look responsive to change. We are almost ready for the future. It's reassuring. So, time is over. Okay, time is over. I would like to thank very much our speaker, our keynote speakers, Kasia, Virginie, François, and Etienne. I would like to thank our facilitator, okay, and I would like to thank all of you attendees.